Hello, and welcome to a new podcast episode of Heart Failure Management Realities, the gap between guidelines and practice. With you, I'm Professor Waleed Al-Habeeb, a professor of cardiology and the president of the Saudi Heart Association. And with me today, Professor Marco Metra, who is a professor of cardiology and the president of the Heart Failure Society of European Society of Cardiology, or Heart Failure Association of the European Society of Cardiology. Welcome, Professor Metra.
Welcome.
So today we're talking a very important topic about heart failure management, inertia, and the gaps and the ways of overcoming that. From the data published and your experience, what is the rate of implementation of guideline-directed medical therapy in current practice?
Yes, thank you for this question. Actually, therapeutic inertia is a major problem that we are seeing across different registries and in clinical practice. We know what can improve the outcome and the quality of life of our patients, but too frequently we don't do what we should. And across different registries, we see that optimal medical treatment that includes quadruple therapy, since the guidelines that I shared in 2021 for the ESC. Optimal medical treatment is given to less than 50-60% of all the patients, and at least one every 20-40% of the patients do not receive drugs that they could receive, because this is the real clinical inertia. Drugs that are not contraindicated, that can be tolerated in that patients and are not given. We know 40-60% of the patients do not receive all the drugs that they should receive.
That's very bad, low actually numbers. So in your experience, what are the most common barriers in implementing and titrating?
And this is also very important, because there are barriers that are due to contraindication to the treatment or lack of tolerance. And here the most common are hypotension, I would say, drugs, above all ARNI, ACE inhibitors, ARBs, but also beta blockers maybe, that lower blood pressure. And so if a patient is already hypotensive, above all when he has a severe heart failure with tendency to a low cardiac output, he may not tolerate these agents. Then we have the contraindications to the beta blockers, going from bronchial asthma to COPD to fatigue and bradycardia. And then the other very important limitation comes from kidney dysfunction. So again, drugs acting on renin, angiotensin, aldosterone axis are may worsen kidney function or have contraindication to their administration because the patient has a too severe kidney function. So hypotension, kidney dysfunction, and intolerance to beta blockers may be a cause of lack of administration of guidelines-directed medical treatment, but there are also a very consistent, meaningful proportion of patients who do not receive drugs, even if they have no contraindication.
So sometimes it's an unjustified fear of side effects, and they're afraid of the side effects, the low blood pressure or the bradycardia, but they should at least give it a chance and try.
Or just inertia. I mean, when you lead a busy outpatient clinic, you have sometimes 15-20 minutes, I don't know, or less, to visit the patient. If the patient doesn't complain of anything particular, the doctor may not have enough time to check and to introduce a new drug. Everything takes time because you have to explain the side effects, you have to explain everything. So it's just inertia because we don't spend enough time.
So one of the important triggers of initiating and starting the guideline-recommended therapies is after a hospitalization. What are the consequences of delaying starting after a hospitalization?
The hospitalization actually may be like a kind of magic moment, and may be an event that rather than being associated with worse outcome, may be the moment where we can change the treatment of the patient and make it far better. One thing that is also well known is that the hospitalization is followed by a marked increase in the risk of rehospitalization, and even death can be from 3 to 15 times higher. The first analysis was done by in the CHARM trial with candesartan versus placebo. So, and the maximum risk is right after the hospitalization. So that it has been called the vulnerable phase, because in these few months after the hospitalization, the patient is at its highest risk. So the hospitalization is a moment when it is of utmost importance to optimize medical treatment, not only check for congestion and give the right dose of the diuretics, but try to optimize medical treatment, giving the drugs that we know that improve the outcome. And it's the optimal time because we have the patient in front of us while still hospitalized, and so we can check kidney function, we can check blood pressure, heart rate very easily, and we know that these drugs may improve the long-term outcome. And these drugs, retrospective analysis of more or less all the trials have shown that the Kaplan-Meier curves, the events are reduced very early. All these drugs, starting from an analysis from SOLVE trial with enalapril, but all these drugs start to act very quickly, and therefore, not giving them, we expose the patient to a risk which is unjustified.
Yeah, increased events definitely will happen after that hospitalization. Does that include both first line and second line?
Oh yes, thank you for also this question, because until now I've talked about quadruple therapy, but we know that there are second line drugs, and a typical example is ivabradine. We know that having an heart rate, resting heart rate above 68-70 beats per minute is a risk factor for increased mortality and hospitalizations in patients with heart failure and reduced ejection fraction. And we know that beta blockers may not be tolerated, not just because they low blood heart rate, but also because they may sometimes cause hypotension, cause worsening of lung function, may just be associated with fatigue and other side effects. And therefore we have the alternative of ivabradine, still alive and well. And this drug, again, it's the best time to be associated to quadruple therapy, maybe the recent hospitalization or also the outpatient visits. Remembering that the heart rate must be kept below at least 70 beats per minute in patients on sinus rhythm.
And sinus rhythm, definitely. So with this issue, what solutions can we provide to improve on GDMT implementation and persistence?
There is inertia, and the inertia has two components. One is the doctor that may not be able to spend enough time with the patient, and the other thing is the patient who at a certain point is unhappy about taking too many pills. Sometimes is unhappy, sometimes is unable, because we know heart failure is a disease of a syndrome affecting elderly patients. Really, it's maybe very difficult for a patient to deal with multiple medications. We must recall that frequently the patient with heart failure has comorbidities, and so he may need to take medications for even other reasons. So the medical therapy is time that the medical therapy for heart failure is simplified, as it is for the treatment of hypertension. And there are advantages now because SGLT2 inhibitors are administered as single administration, single dose, so you don't have to change too much the rest. A mineralocorticoid antagonist, they don't have many doses, and then of course you may need to play with the other drugs, different doses of beta blockers or the beta blocker
Right. So obviously shared decision making might help here. How would that and patient education have a role in implementation?
It has a very important role. Again, education takes time. I don't know about your reality. In Italy, nurses are not that much available. There is a lack of nurses. But for example, being helped by a nurse may have a major role. Then there are different systems, alerts. But whatever needs also that the patient understands the technology. So I think the human contact is a major role, but we are facing a lack of doctors and even more of nurses, at least in Italy. Yeah?
It's a universal problem everywhere, and it's mostly based on the physician and the cardiologist, the limited time availability, the limited specialized people, and again, it's a multidisciplinary approach. Many people are involved, and that's the crucial point. But how do you see then other means of education, like social media and education channels, other than the just direct face-to-face?
Also very important. In that case, for example, as Heart Failure Association, we have this website, heartfailuremeters.gov, and barrier is the language. Again, I mean, above all in Europe, so it would be nice, but for example, with the AI, avatars, there is a way to make it easier, the use of different language, the translation in different languages. And this way, of course, having messages that are, and we must remember that we must be simple, because when we talk with the people, but making patients understand and realize how much life can be prolonged, hospitalizations reduced, quality of life improved, with the treatment recommended by the guidelines, is very important.
I think most people are always on their phones and they have access. And unfortunately, most of social media messages are made against medical therapy. They always fear people from taking medications, from following, from this. And I think this is our role probably, to reach out to them on these social media channels, as you said, simplifying the message, making it clear, reassuring patients that this is very important for them to adhere to the medications for better outcomes, no doubt. Now, as you mentioned as well, that many patients will fear taking so many pills, and sometimes I don't blame them. They might have lots of diseases, and they have medications for heart failure, for ischemic heart disease, for hypertension, for diabetes. How would a single pill combination help in such compliance?
I think it will help a lot, because it will simplify therapy. It has been widely demonstrated for hypertension treatment. Heart failure is another. It's used, combinations are used for COPD treatment. You have different combinations, so there is no reason to think that they are used in diabetes. Actually, I mean, heart failure, we are really late because we liked the art of treatment and this thing, of course. But now, I mean, it's time to have combined therapy, combined pills, also for heart failure.
Yeah, it's true. Great. Any other solutions or advices you would like to provide? Thank you very much. Great. It was a great meeting talking about very important topic of inertia and how to overcome it and solutions behind it. I do thank Professor Metra for his time and his valuable information. Thank you very much. Have a good day.
Thank you.